have Dr. Cohen, who will be talking about botulinum toxin for post-amputation pain. He's from Department of Anesthesiology, Northwestern Medical Group, and he will be joining us virtually. But thank you so much.
Dr. Cohen, can you hear us? We cannot hear you.
Okay, now can you hear me?
Yep, now we can hear you. Thank you.
Okay, better, thank you. So at the end of this talk, I hope that this talk is going to be on botulinum toxin for post-amputation pain, and I want people to be familiar with the heterogeneous mechanisms for both understand the evidence and the rationale for using botulinum toxins for post-amputation pain, and differences between regional and systemic administration, and really to provide the results of our very recent comparative effectiveness trial against standard medical and surgical treatment and areas for future research. So, like I say, post-amputation pain, this is a symptom. It's not a disease. There are multifactorial mechanisms. There are different mechanisms that can exist within the same person. So this makes pain treatment different. I think most people recognize that mechanistic-based treatment of pain is better than symptom or disease-based. There are different ways to try to categorize mechanisms like quantitative sensory testing, functional imaging. We've used infusion tests, but they're difficult. So, in your brain, there's a somatotopic representation of your body called the homunculus. You have a motor and sensory homunculus. And, that part of your brain is used to getting signals from parts of your body, like your leg. And then when your leg or your arm is no longer there, your brain reorganizes. And studies have shown a correlation between the size and intensity of phantom limb pain and the amount of cortical reorganization. This can involve both inhibitory and excitatory, like glutamate neurotransmitters. There are some studies that show that failure to reorganize can cause phantom limb pain. So it can work both ways. Gray matter is decreased in areas corresponding to the amputated limb and correspondingly, increased others. And, there have been several studies that showing things like opioids, using different prosthetics, regional anesthesia can diminish reorganization and hence pain. But it's probably not a particular kind of pain relief. It's probably pain relief in general. This is an article that we did basically on deafferentation pain, just kind of showing here this is not unique to phantom limb pain. This happens with pain after a stroke, spinal cord injury, brachial plexus avulsion, even people with diabetes. Right? They can't feel their feet and they hurt. This is deafferentation pain, a deafferentation pain phenotype. There are spinal mechanisms. There's reorganization in the spinal cord as well. A lot of this is anecdotal. For example, a person who had phantom pain, then it disappeared. They developed other neurological symptoms, were found to have a spinal tumor. And when that was resected, it came back. We've done, reports on people with phantom sciatica from a herniated disc and getting epidural steroid. And one of the other, cases was someone who had new phantom pain in the arm. And as they were being worked up, they developed a shingles rash. They basically had phantom shingles. So there's other mechanisms. We know that there are peripheral mechanisms. This is a very big thing now. There's a correlation between, residual limb and phantom limb pain. There's sympathetic components. If you inject like norepinephrine around neuromas, it can elicit both. People have Tunnel signs. Prosthetics can provoke phantom limb pain. And when you inject local anesthetic and other substances, like around the dorsal root ganglia, you can relieve it. And lots of treatments are, really aimed at the end neuromas. As I said, we know which nerves get cut with amputations, the femoral nerve, the sciatic nerve, different nerves of the brachial plexus. There's retrograde influences of injury on excitability of central terminals. We've done work here with sympathetic blocks, i.e. sympathetically maintain pain, showing that they alleviate phantom pain more than residual limb pain. And as I said, lots of different peripheral treatments like radiofrequency ablation, alcohol neurolysis, cryoanalgesia can relieve not only residual limb but phantom limb pain. And here's just an illustrative, picture of somebody with phantom finger pain and a Tunnel sign, and then it's resected, and at least in the short term, it's better. Stump pain, or pain after a planned amputation, it's like other forms of persistent post-surgical pain. There are some differences, right? So, poor fitting prosthetics can do it. After traumatic amputations, there's a lot of heterotopic ossification. Since diabetes and vascular disease are the leading causes, they can have residual ischemia. Even a leg length discrepancy of 0.5 centimeter is associated with back pain. So when you get your leg cut off, most of these people, over 2/3, have back pain. So, botulinum toxin, people know, Botox. It's it's a neurotoxin, and what it does, is it can inhibit the release of neuropeptides and neurotransmitters involved in pain from A delta and C fibers and dorsal root ganglia, such as calcitonin gene-related peptide and substance P. It decreases, the inflammatory milieu. Sodium channels proliferate after nerve injury, hence the new drug that was approved, suzetrigine, and this can block them, and like I say, it reduces the inflammatory milieu. If you look at systematic reviews, there's well over a dozen placebo-controlled trials for botulinum toxin for a whole host of neuropathic conditions. Almost all of them are positive. I would say that that a lot of these are industry sponsored. In these cases, the botulinum toxin is usually given subcutaneously or into muscle or intradermal. It's been looked at a few times for post-amputation pain. My colleague Paul Pasquina looked at it for hyperhidrosis. They didn't report the values, but said that it did not relieve post-amputation pain. And then there are two positive, really comparative effectiveness trials that suggest benefit, but these are very small. I do this slide very quick, right? If somebody comes in, to my clinic and they have sciatica or they have acute inflammation of joint pain, I'm not going to give them systemic steroids because there are a lot of side effects and they don't work that well. So depending on the drug, I'm going to give them an epidural steroid injection or a joint injection with steroids. It's going to work better. There will be less side effects. And you can see this with some drugs, from the slide here. So the mechanism of action of botulinum toxin suggests that if you can inject it around a nerve, like in an end neuroma, after an amputation, it will work better. So we received, Restoral funding to design kind of a post-amputation pain study in Ukraine to have them join our ongoing randomized trial examining ketamine and stellate ganglion blocks for PTSD and TBI, and then to look at what they're doing. And so that's where this comes from. We compared people who got botulinum toxin, it was a prospective study, to people who got very, very comprehensive medical and surgical treatment, which included injections, surgery, and many things like ketamine infusions, RTMS, psychotherapy. Everybody got medications. And, botulinum toxin was given in almost all cases using ultrasound around the end neuromas, so around like the sciatic neuroma. And it was also given subcutaneously in people with peripheral sensitization and sometimes into trigger points if any were identified. This was not a randomized trial. We have one that we're hoping to start by January. So, baseline scores were higher in the botulinum toxin group. They were a little bit more likely to be on opioids. People in the comprehensive medical and surgical treatment group had higher concomitant conditions like PTSD. And it was kind of surprising what we found. Out 1 month, the reduction in the average phantom limb pain and the responder rate for phantom limb pain was higher in the botulinum toxin group. It did not work as well in the residual limb group. But at 3 months, almost everything favored comprehensive medical and surgical treatment. So in other words, it was better phantom pain at 1 month, but not at 3 months. In fact, getting very comprehensive multimodal care was better. And if you look at systematic reviews on botulinum toxin, they seem to last the median is about 75, 76 days. These are the graphs, the multivariable analysis graph. Probably the biggest effect was, were baseline pain scores and duration of pain. But in the chart on the, and you could see, shorter duration, better outcomes. But the very positive thing is, like I say, almost everybody had neuromas injected. And the more neuromas that were injected and the higher the botulinum toxin dose, the better the outcomes. So, in conclusion, there's evidence for botulinum toxins for neuropathic and non-neuropathic pain. We need better studies, preferably federally funded. There's a lot of, indirect evidence and now more direct evidence that perineuronal botulinum toxin, because of how it works, would be better than systemic administration, but we don't have any randomized controlled trials. This would be similar to joint injections with steroids or epidural steroids. We found that botulinum toxin might possibly be more effective for phantom limb pain, but not residual limb pain at 1 month. But at 3 months, comprehensive medical and surgical therapy was better. And then, future research should obviously use a placebo control, compare it to active comparators, because phantom limb pain and residual limb pain are really multifactorial. And based on the mechanism of action of botulinum toxin, it's possible that add-on therapy works better. So do you have additive effects or synergistic effects even? And then, of course, determining the effectiveness of repeat therapy. Is it less effective, equally effective, or maybe do you get some kind of cumulative effect? Thank you.